brought to you by the Dao Health.
This is Delve, a podcast that endeavours to enlighten and support you in understanding and transforming your own health.
Hello, my name is Elizabeth Cullen and my co-hosts are Clarice Berry and Molly Burton. And together we will be drawing on the Dao Health's signature and unique integrative approach to traditional Chinese medicine.
So take a seat at our table, grab a tea, and let's dive deep into the enduring legacy and evolution of medical practices over time.
This episode is proudly brought to you by the Dao Health. Calm is a thoughtfully crafted, custom Chinese herbal tea blend designed by a traditional Chinese medicine practitioner and Chinese herbalist to support women in nurturing their Yin Feminine energy and spirit or Shen. Using the benefits of Chinese herbal medicine, this tea helps to balance the flow of qi and blood within the body and calm the central nervous system. Calm is perfect for any time of the day and offers a slow and peaceful moment of yin. Thank you to our clinic, the Dao Health, for making this episode of Delve possible.
Hello and welcome back to Delve. I'm Clarice and I'm joined by my co-hosts today, Miss Molly Burton and Elizabeth Cullen.
Hello.
How are you guys today?
Yeah, really well. Ready to dive in.
Ready to dive in. So on today's episode of Delve, we're going to talk about the oral contraceptive pill. We're going to talk about how to support your body to transition off the pill. And we're also going to be hearing from Dr. Nancy Peters, an obstetrician, gynaecologist, and advanced laparoscopic surgeon who will share her insights on the oral contraceptive pill and answer some of our listeners' questions. Did you girls ever go on the pill in the past?
Yes, I did go on the pill when I was in my early teens, purely for contraceptive reasons though. I had a boyfriend and mum's like, okay, time to go on the pill.
It's time.
But then I chose to slowly transition off the pill when I started my TCM degree actually.
Yeah.
And just learning more about my body and wanting to be more in tune with my hormones.
Yeah. What about you?
Yes, I went on the pill for 3 months when I was early 20s for contraceptive reasons, and it did not agree with me at all. I begged my mum in my teenage years. I was like, all the girls, they've got this really clear skin, their breasts are large and full. Can I go on the pill? And mum, being in health, was like, no, I would prefer you not to. You don't need to for your cycle. And from a contraception side of things, I didn't need that at that time. So, yeah, I didn't have any experience until my early 20s. And when I tried it, I was like, oh, this isn't for me.
What did you feel? What was different?
I bled for 3 months. So I bled for 3 months. It made me hormonal and I put on weight. So I was on Levelin, which now knowing, I'm like, that wasn't the right pill to go on. I tried Yaz after that. And I think I'm very fortunate. I have a good cycle.
Yeah.
I have an efficient bleed. So I think there was nothing wrong to begin with. It was purely for contraception. I was like, oh, this isn't worth it for me.
Yeah.
That was it.
Yeah.
No more hormones.
That was it. I was like, I'm done. And then I was studying Chinese med by then. So I was just like, oh, look, I've tried it. My body's been like, no, sister, that's not happening. So then onwards and upwards.
Onwards and
left it in the
upwards.
past.
Yeah.
What about you, Clarice?
Yeah.
Yes, I think every woman, not every, but a lot of women take it as a rite of passage. When I was going through high school, entering my early adulthood and feeling like I'm an adult now, most women in our year group actually just went on it because it was like, that's what everybody did. Everybody went on the pill. I went on the pill. My sister went on the pill. I was on it probably for 3 years from year 10, so quite young. But again, I got my period quite young too. And I was having a lot of cycle problems at that point, and that was the first thing offered to me. But I came off the pill around year 12, I think, when I was really getting interested in natural ways to support my body. And boy, did I have a bad transition off it. I had bad cystic acne breakout across, and mind you, I was doing the HSC too. So I was like fully stressed.
Not the right time.
So it'd be good to go through how we can effectively transition off the pill to support our hormones in this episode too.
Definitely.
Yeah. When I asked our Delve community on whether they too had taken the pill, over 96% of them said yes. So it's a lot of people that have been on the pill.
I'm really curious with that next generation of girls that are coming through now, how many are taking it, because the awareness is so much larger of the implications of taking the pill and that it's not actually the best approach for every woman.
No.
So interesting from an age perspective.
Yeah.
What's happening with that next
Definitely.
gen?
That is really curious.
Things are changing.
Yeah.
Definitely.
Oh, absolutely.
Yeah.
Definitely.
So we're going to move into our dynasty segment now and delve into the making of the oral contraceptive pill. So I don't know if you girls did this subject. When I was doing my master's in Repro Med, we did a contraceptive subject. Do you guys remember when they were talking about those ancient methods of contraception? There's one that stuck in my head vividly. Women in ancient Egypt used to make pessaries out of like acai leaves or lint or even crocodile dung.
Wow.
And they would insert that vaginally to act as like a barrier method of contraception because it would block the entry of sperm through the cervix. But also crocodile dung would be so acidic. So it probably acted as a spermicide too.
It's really smart.
Isn't it really?
Wow.
Like, isn't that incredible? You think, oh, I don't know if I want that there. But how smart is that at that point in time?
Fascinating. And women would do anything, right, to be able to have control over their fertility even in those ancient periods. I remember from that subject clearly about the camel skin condoms.
Oh my gosh.
Do you remember that? And I remember visualizing that would not be comfortable.
Yeah, I was like,
How do we make?
Was it like a sock or what was it?
They're very interesting. They're also incredibly smart.
Wow.
Love that.
Absolutely.
Love that. So the development of the first oral contraceptive pill was a pretty remarkable medical development. It was really happening at a time in the 1960s where women's rights were coming through and we're seeing a lot of movements of sexual liberation as well. So the making of that pill really did give women a sense of freedom. It changed that household environment from being we're stay-at-home mums and we're reproducing now to we can have a career, we can actually go out and we can have sex for fun and for pleasure, and we don't just have to do that for reproductive reasons. So the pill was remarkable in propelling a lot of those women's rights as well. So the first oral contraceptive pill, called Enovid, was approved in the US by the FDA in the 1960s, which this was a combined form of contraception. So it was a form of synthetic estrogen and synthetic progesterone. And if you remember all the way back to our first IVF episode in season 1, we talked about two scientists, Gregory Pincus and John Rock. They sort of laid the groundwork for the development of this pill. Then they actually combined and collaborated with two women. One was Margaret Sanger, who was a women's rights advocate, and Catherine McCormick, who was a philanthropist. They both championed the development of the first reliable contraceptive pill.
Which I didn't know that.
Amazing, right?
I didn't know that either.
Yeah. And like as they they were just like, come on, let's go. Because originally that Enovid, if I'm pronouncing that wrong, sorry guys, but Enovid was designed originally to treat heavy menstrual bleeds and irregular cycles. That was why it was brought forth. And when they were doing the clinical trials on the pill, they actually saw that these women were having suppressed ovulation. And they're like, oh, this could be used for a contraception, contraceptive. But of course, at that time, there wasn't a lot of women's rights. There was a lot of pushback on actually, should we develop that? So in 1960s, the pill was then approved to be used as a contraceptive. But unfortunately, Enovid contained a lot of really high amounts of hormones in that pill. So women were coming forth with a lot of symptoms like headaches and nausea and those sort of symptoms, but also some scary things like blood clots, liver dysfunction. So when we actually look at comparing the estrogen doses in that pill and to what we currently use today, 150 micrograms of ethinestradiol, which is the synthetic estrogen, is what was in Enovid. And today we have less than 30 micrograms. Wow. So it's a pretty big difference.
4 times worth.
No wonder there was all those side effects.
Yeah, exactly.
Yeah.
But you know what? Women would have done anything, right, to have that choice.
Yeah,
so,
exactly. Yeah. And the first thing that was available on the market at that time.
Yeah.
So today's pills are actually based on this first contraceptive pill, but they've done a lot of more efficacy and safety data studies to make sure that there's less of a risk profile. So most of our pills today, as we know, we've both got combined oral contraceptives, which use estrogen and progesterone in their synthetic forms, or we've got progesterone or progestin containing only pills. And as of 2019, over 151 million women worldwide were using the oral contraceptive pill, making it the third most popular contraceptive method globally.
That's a lot of women.
That's a lot. In Australia, approximately 70% of all adult women use some form of contraception, with 33.6% of which actually use the oral contraceptive pill.
Okay.
Now we use the pill to treat all sorts of conditions. So we have women on there for Some people go on it for acne and to help support their skin, for endometriosis and period pains, and also for management of PCOS or polycystic ovarian syndrome. And interestingly, there's some exciting ongoing research now into the creation of male contraceptives. Finally, they're finally happening. They're running clinical trials now on a testosterone and progesterone topical gel that they can apply daily to suppress spermogenesis or the production of sperm. And then they're also making a hormone-free pill that works by blocking a receptor to stop sperm production without affecting testosterone levels.
Because we wouldn't want men to have any side effects from contraception.
No.
And how much are they going to be putting the topical gel on? Are they going to be on it, or are they going to be like, oh no, I just won't put it on today?
That's the thing.
I forgot today. I'll do it again tomorrow.
Sorry.
It's all good.
Hopefully it's good incentive. Like if you don't want a baby, put that gel on. Yeah. So
Yes. Wait and see.
super interesting. So now we are joined by Dr. Nancy Peters. Dr. Nancy Peters is an obstetrician gynaecologist based at Sutherland Hospital, Kareena Private Hospital and St George Private Hospital in Sydney, Australia. Nancy holds a Bachelor of Medicine and a Bachelor of Surgery from the University of Adelaide and a Masters of Health Leadership and Management from the University of New South Wales. Her passion for providing women with the highest standard of surgery led her to undertake a fellowship in minimally invasive gynecological surgery after specialist training at Ransgog. In addition to her busy clinical practice, Nancy advocates for women's health through a keen interest in research, teaching, and mentoring resident doctors, and has presented nationally on endometriosis and adenomyosis. Welcome, Nancy. Thank you so much for joining us.
Thank you so much for having me.
So we've got some questions for you about the oral contraceptive pill. First off, how does the oral contraceptive pill work?
So the oral contraceptive pill, there's two different types. There's the combined oral contraceptive pill, which contains both estrogen and progesterone. And there's also the progesterone-only pill. In terms of the combined oral contraceptive pill, which is what's sort of most commonly known as the pill, that works on the HPO axis. So if you imagine that the HPO axis, which refers to the hypothalamic pituitary ovarian axis, that's kind of the brain control center for our reproductive hormones. And the hypothalamus in the brain releases GnRH, which then acts on the pituitary gland to release LH and FSH. And they're kind of two hormones that are responsible for growing the follicles that ultimately release an egg, and LH is responsible for ovulation. So the estrogen suppresses the FSH, so those follicles from developing, while the progesterone thins the lining of the uterus, thickens the mucus at the cervix, and also works to prevent ovulation. So the two hormones work synergistically on that kind of HPO axis, or kind of hormone control center.
Wow. Yeah. So the body sort of feels like, oh, I've already got plenty of estrogen and progesterone in the system, so it doesn't need to produce its own?
Well, it works on the negative feedback of that hormone cycle. So it's really quite clever how they came up with the combined pill.
Yeah. Wow. So we know that the pill can be used for contraceptive reasons, but why is the pill beneficial for other conditions like PCOS or painful periods, endometriosis?
Yeah, that's a really great question. Again, it comes back down to both the estrogen and the progesterone. So endometriosis is a condition where tissue similar to the lining of the uterus is found in the pelvis outside the uterus. And so using the combined pill stops your periods with endometriosis, so can stop pain in that way. But it can also suppress the growth of the lesion. So that progesterone, in the same way that it thins the lining of the uterus, has a similar effect on the endometriosis lesions. PCOS is a bit more complex. So there's a couple of aspects of PCOS. One is that you're not having regular cycles where you're ovulating as part of the hormone imbalance of the condition. And so what can happen is, over many years, untreated, unchecked, that lining of the uterus can thicken, and it does pose a risk of cancer of the lining of the uterus. So the progesterone part of the pill helps thin that lining and decrease that risk.
Mm.
But also part of the hormone imbalance of PCOS means that there's increased androgens or male type hormones being produced. And so the pill can suppress that. And that's useful for some of the aspects of PCOS, such as hirsutism, so hair in places that you wouldn't expect to have hair, acne, or even the hair loss aspect of PCOS as well. So the pill has a number of uses across both of those conditions.
Yeah, great. So, Nancy, when wouldn't you personally prescribe the oral contraceptive pill?
Any decision to use hormone really needs to be a shared decision with the patient. So obviously, if a patient doesn't want to be using hormones, that's the most important factor that we take into consideration. But there are some medical conditions where we shouldn't be using the combined pill, and that's because of the estrogen component of the combined pill. So we wouldn't use it in someone that has current breast cancer. We also wouldn't use the pill in someone that has a clotting risk. So that might be in the first 6 weeks after birth if they're breastfeeding, or if they have additional risk factors for clotting, if they've had any migraines with aura, those vision changes that you can get, any heart disease, if they're after a certain age and smoking, high blood pressure, history of blood clots or clotting disorders, or if they're planning some major surgery or a time where they're not going to be moving around. So all of those kind of clotting risks.
Yeah.
Another thing that's really emerging with the combined pill is also patients that have had bariatric surgery or weight loss surgery, or might be on weight loss medications. And that's something that we need to also think about and be careful about, because absorption can be altered. So especially when we're using the pill for birth control, we need to think about the absorption of it and whether that's going to be the right choice.
Yeah. Oh, interesting. Yeah. Different world that we live in now with all these weight loss medications.
Yeah, exactly. Yeah.
Okay. So could you briefly go through the different types of pills that are available on the market?
So there's actually more than 30 different combinations of pills on the market. So I probably won't bore you with all 30 of those combos. But in general, there's about 3 main types of estrogen. And then there's up to 9 different types of progesterone. And the progesterones sort of labeled into generations, but that's actually more based on how they were introduced into the market. And the difference between the different types of progesterones are that as we progress to the slightly more newer ones, the clotting profile is very marginally different with the newer types of progesterone. And also the androgenic activity varies across from the older generations to the newer generations as well. So there's lots of nuances to how we go about picking the right pill. And that, again, is really a shared discussion. Generally, where possible, we try and use a lower dose of estrogen to begin with, balancing the fact that sometimes using too low a dose of estrogen can cause breakthrough bleeding, which can be really annoying. And unfortunately, with the progesterone, it is a little bit of trial and error, and that's the hard part of the combined pill, that we know that there are side effects from the progesterone. And so we try and really tailor our choice, but sometimes it can be trial and error to work through those side effects and find the best pill for you.
Yeah, great. This is like a lot of trial and error. I think I've got lots of patients that come into clinic and they have cycled through a couple of different pills, and then once they have found the right one, it's worked really well for them.
Exactly, yeah.
So last question for you is, if someone misses a pill, what's the best course of action?
Yeah, so that's really critical where we're using the pill for birth control or contraception. So if it's been less than 24 hours, then take the pill straight away. And that might mean taking 2 pills in the same day, but the pill should generally continue to work. But if you're more than 24 hours overdue and you've missed the pill, then again, taking it straight away. And it would be really important to use an additional form of contraception or birth control, such as condoms, for the next 7 days. And then if you're within the 7 days of your next hormone-free break, you can skip the inactive pills or sugar pills and just continue on with the active pills. And you can also consider emergency hormonal contraception as well, particularly if it was less than 7 days since you were last on the inactive pills as well.
Now, we actually have a segment on our podcast called Dear Dao Does. And so one of our listeners has sent in a question for you to answer, Nancy. Their question is, will the pill impact my libido? If so, how?
So this is really interesting and something that you just get such a varied response when you talk to people about their experiences on the pill. And the other thing is, of course, that libido is so multifactorial. So there's so many factors that contribute to it. There's actually a paper about this because it is an important symptom to address. So a systematic review, which is a type of study where they put together a whole bunch of other studies, and that was published in 2013, looking at 36 studies and more than 8,000 pill users. And they found that for most women, their libido was unchanged. 22% reported an increase in libido, while 15% reported a decrease in libido. And so again, the variations in the pill and everyone's experiences really does happen. And so, again, it might take some experimentation with moving through those different types of pills and different types of progesterones. But certainly if that's something that's happening, whether your libido is impacted, it's really important to have a chat to your healthcare provider and try and work through that, obviously, to find a type of hormone medication that's best for you.
Yeah, great. Really, really good. Thank you so much, Nancy, for coming on. It's been fantastic having you on today. I know you're a very, very, very busy lady and you're in between patients today.
Thank you, Nancy,
Thanks,
for sharing your
Nancy.
insight. Really
Thank you
appreciate
so
it.
much for having me. Lovely chatting to you guys.
Nancy was such a wealth of knowledge.
So interesting. So great to hear all the different conditions that the pill can be supportive for.
Yeah.
But then also the reasons why we might not prescribe the OCP.
Yeah.
Exactly.
So when we actually polled our listeners about whether they took the pill for contraceptive reasons only, 64% of them said no. And I would find in my clinical practice that the majority of women actually on the pill that I see are using it for management of endometriosis pain a lot of the time, and regulation of their cycles from a PCOS perspective. A large proportion of our patients also come into clinic because they want to transition off the pill effectively, which is amazing because I think a lot of people once upon a time would just stop the pill and see how it goes. But now I have patients coming in saying, hey, I'm thinking in 3 to 6 months' time of coming off the pill. Can I come in for some treatment? What supplements should I be on to effectively transition off? So I've definitely seen that change, which is amazing. Interestingly too, when we polled our listeners about whether they noticed a change in their menstrual cycle, i.e. irregular periods or missed periods when coming off the pill, 61% of them said yes. So now that we know a little bit more about the pill and why we can use the pill, I wanted to have a discussion with you girls for our listeners today about how our listeners can effectively transition off the pill, regulate their hormones and have a bit of a smoother transition. Like I said at the beginning, I had a pretty terrible transition off. So first and foremost, girls, what's happening in our body when we're on the pill and how does that affect our cycles?
So I think Nancy explained that really well about the HPO axis, so the hypothalamic pituitary ovarian axis. But from a Chinese medicine side of things, we talk about the Baomai channel as well. So I'll talk about both. I want you to picture the connection from the reproductive organs, so from the uterus and the ovaries and the messages that are sent up to the brain and then back down, as if that's been blocked with taking the pill. And in Chinese medicine, we see the Baomai channel, which connects the heart all the way down to the uterus and through to the ovaries, that's also blocked. So for example, with your history there, Clarice, you first got your period at 11 and then you went on to the pill at
I would have been in year 10, so
16 roughly,
yeah.
15, 16. So we know that it takes 5 to 7 years for the body to regulate its own hormones. Often when women start taking the pill, their body hasn't had the opportunity for that time to regulate. So the body goes, okay, I'm trying to do this thing and I'm trying to ovulate and I'm trying to get a period. And then, okay, we're not doing that anymore. It's been switched off. So Chinese medicine will say like the ovaries are sleeping. They're sleeping. They're so tired. But they're sleeping. And I think we need to give the body grace and understand that the body needs time for those ovaries to wake up and for the HPO axis to regulate again once coming off the pill. Because depending on when you've gone on it, depending on the reasons why. So, for example, if you didn't have a period before and then the GP said, you know what, let's go on the pill and we'll discuss this in 10 years when you're ready to conceive. Red flag, by the way. then you've got to think about those underlying conditions of what was already going on at that time and what was the reason of why you went onto it. So I think understanding that first off is a really big step forward to then understanding why you need to be patient and look after your body when coming off the pill.
Yeah, great. Really, really good. And I would say, what sort of advice would you be advocating for our patients, or what should they take on board if they want to transition off the pill?
Yeah, I think, we're in that era where we all went on the pill quite young. And then we've been on it for a significant amount of years for some particular patients. And then they're ready to then maybe enter more of their family planning or entering that next phase of their life. So we have many women that come into the clinic on the pill, and then we're thinking about, okay, how can we transition off the pill? So especially, I know one of the big questions is for our endo patients, for example, those that are on the pill to help currently manage their symptoms and what it will look like coming off it. And that can be very scary because
very daunting.
It's helped them through this time, and now it's like, okay, we're going to take this away. What's it going to look like? So I think coming into the clinic, giving yourself a good 3 months of acupuncture treatment and supplement support, herbal support. The first thing in terms of endometriosis pictures is to help decrease inflammation in the body, get that bowel mind connected, get the blood flowing through the reproductive organs. And then we're thinking about, okay, we're going to transition off the pill in say 3 months time. And then we're going to continue our acupuncture treatments all the way through to when we hit that tip of the iceberg as we talk about it. Yep. So when we come off the pill, the tip of the iceberg typically happens around 6 months post OCP cessation. For some women, it could be a little bit later, but making sure that we're consistent with continuing our treatment plan, continue our supplementation, and potentially adding in some Chinese herbs there as well.
And then when we talk about the tip of the iceberg as well, that's because you still have those synthetic hormones in the body. So often women will be like, I got my period back. This is great. My skin is still clear. Happy days. I'm not getting those painful periods. And it is around that 6 months post cessation of the pill that your hormones are now being used primarily, and those synthetic hormones have now decreased and gone. So from your body. But I think also I always have the discussion with patients around what does the next 3 months or the next 6 months in your life look like? Because if they're going into their HSC or their final year of uni, or say, for example, they've got a wedding planned, that is not the time to come off the pill. I always say, look, let's look for an open window where the next 3 to 6 months is going to look like for you, where you don't have a big trip planned. In Sydney, I'll usually propose it as winter. Like what's the plans for winter? If it's going to be a slow few months for you, then that would be a time to start thinking about coming off the pill. And through that education, when Molly was saying, if you've got that opportunity to talk to a patient prior to coming off the pill, we want to do all the education around that time. We want to do functional blood tests so that we can make sure that you're in a place of abundance. So often the pill can actually, from a medication perspective, deprive you of zinc and magnesium, and it can actually increase your levels of copper, so those heavy metals. So we want to work really hard on increasing that zinc and magnesium before you come off the pill, so that you're in a place of abundance or balance rather than deficiency. And I find that that's much more of a smoother transition.
And also on that front of depletion of nutrients, your B vitamins are not well absorbed when you're on the pill. And so thinking from a preconception standpoint with your folate levels and that absorption, if you're thinking, I'm going to come off the pill straight away and then start conceiving, making sure that you're on a really good folate, high quality absorbable folate in that 3 months to 6 months or beyond before actually coming off the pill, so you've got a plenty amount of that nutrient to support early pregnancy too.
Absolutely. And I think it's also really interesting, and I'm loving this in clinic, is that many women in their early 20s to mid 20s, they're not coming off for preconception reasons. They're coming off because they want to learn about their cycle.
Which is amazing.
Amazing. And they want to be able to work with their own hormones, which is the best gift you can ever give yourself.
100%.
Because interestingly, with the research with the pill, you know how when they say, I'm completely digressing, sorry, but it's really interesting fun fact. But you know how they speak about finding a partner whilst you're on the pill?
Yes. And pheromones.
And pheromones are completely different to when you're off the pill.
So
I find that's fascinating.
Funny enough, when I first met my now husband, he asked me, are you on the pill? because he's into his research. He already knew
did he know that?
And he was like, because I've
Oh.
heard that women like dislike their partners when they come off. Are you on the pill? And I was like,
I
no.
love
And
that
he's like,
so
oh, great,
much.
we're all
Is
set.
this a red flag?
We're good.
Yeah. He was like, great.
Very interesting. But I think also
yeah.
on that, Liz, with the pathology testing, very interesting. Something I always highlight to my patients, you know, doing your testing whilst you're on the pill for those baseline minerals, e.g. vitamin D, massive precursor for your sex hormones. If your vitamin D is in insufficient amounts, then that doesn't set you up very well for that HPO axis to switch back on and get those hormones firing. But then on actually testing the hormones, we do not test the hormones until at least 3 bleeds post-pill.
And don't test them while you're on the pill.
No.
GPs, you've gone all the effort to go and get these blood test referrals, and then patients will come back, they've been proactive. I've got all my bloods done, and you can see that their hormones have been checked. All the AMH has been checked as well. I'm like, none of that's accurate.
Yep.
Let's disregard that and talk about it in 3 months. And also, just super quick, is that it can be expected that your period is not going to come back for up to a year.
Yeah, manage your expectations.
Coming off the pill.
You might not have it for 3, 6, 9, 12 months post coming off the pill. And also managing expectations, especially those young patients who are coming in like wanting to learn about their bodies. Skin and acne breakouts is a huge concern for them. And it's knowing that when you're on the pill, your endogenous testosterone production is sort of suppressed. And because that's suppressed, which can affect, of course, libido, our energy can change with that. Your body tries to upregulate how much testosterone is in its system. So when you come off, it's still producing a high amount of that testosterone. And progestin can sometimes act a little bit like testosterone in your body too. That can lead to your skin having a huge flare-up post coming off the pill, and it scares a lot of patients.
And then they go back on.
And they go back on the pill. And I'm like, you've got to ride the wave. You're on all the right nutrients. Give your body the grace it needs and the time it needs for your hormones to balance itself out. And then your skin should be nice and clear unless there's something else going on that we need to address.
Sometimes those symptoms can become more rocky, and I always say that's the HPO axis switching back on.
Yep.
Yes.
Yeah.
It's doing what we want it to.
And if their period hasn't come back yet, but they're starting to get some acne, it's shifting that perspective rather than, and cervical mucus, it's shifting that perspective of like, all my symptoms are coming back, the stress associated with that, which I can understand can be triggering. But at the same time, that's your body saying, hey, I'm using my hormones again. I'm working really hard to get us a period.
Yeah, which is good.
What are we doing with acupuncture, Liz? Like, how are we activating the HPO axis? What types of points are we popping in the body?
Okay, good question.
Like, you know, in terms of what to expect for acupuncture and how that supports transitioning off the pill.
So when you think about the HPO axis, the brain side of things, so do my 20, so coming all the way up here, and then you're coming all the way down to zigong above the ovaries. So that's already going to start getting that communication in those messages, signals to say, come on, let's wake up again, let's turn back on, let's wake up those ovaries, let's get the blood flow through to the uterus and through to the ovaries to get that function increasing. And then from that my perspective, we're opening the heart, and then we're going to allow that chi and blood flow to come all the way down from the heart, circulating through to the uterus and the ovaries as well. Then you're looking at all those other symptoms that are happening. So if there is inflammation, so period pain or any pelvic pain, then you'd be treating that. And then you're also doing those distal points to help with nourishing that yin and blood flow, and then helping with mood changes as well, because that's something that can be expected.
Yeah, great. So do you guys have any top recommendations for patients who are wanting to learn about their cycles or transition off the pill? I would say, 1, listen to season 1, episode 5, Understanding the Menstrual Cycle of Delve, because we talk a lot about like the basis of your cycle and how to look after each phase. So that's good about relearning and getting in tune with your body as well. We love Dr. Lara Bryden. We love her period repair manual book. In chapter 2, she actually has a segment called Breaking Up with Hormonal Birth Control, which is great.
Definitely. And I think as well, you know, coming off the pill, making sure that we have our favorite app that we like to track our symptoms and our first bleed, and then becoming familiar with the changes of your cycle. So logging that on your app, and you can go through that with your health provider or your TCM practitioner to really understand and begin to know how your hormones shift through the month.
What app would you recommend, Molly?
We use Clue app or we use Flow app, but just finding something that's super user friendly, really straightforward. We can see the cycle days that are on the day of the calendar,
Yeah.
and just making sure it's really clear.
Yeah, really clear. I was also going to say not everybody likes to do basal body temperature charting, or practitioners don't always like to look at that data to treat their patients, which is fine. But if you're somebody who your period hasn't returned after the pill, you're a bit confused where you're at, sometimes testing your basal body temperature every morning, again, it's very, it can be very inaccurate because we need a lot of data and all these things have to be in a line for your temperature to be read accurately. But Fertility Friend, it's an old app, but it's a good app, and it gives you a good reading of your biphasic pattern of your cycle, meaning your follicular phase where your temperatures are low and your luteal phase where your temperatures are high. And a really good thermometer that you can use is called Temp Drop. A Temp Drop thermometer, it wraps around your arm and it takes the average of your body temperatures overnight, or the Oura Ring, like we talked about in your menstrual cycle episode, Molly. That's also a really good tool to sort of get familiar with what's happening in your body.
I just wanted to add as well is that a patient-centered care team around you is really important. So a GP who's aligned and listening to what is happening with your body and symptoms, a GP who's specifically women's health trained, and then if it feels right for you is having an acupuncturist and a Chinese medicine practitioner. You may also have a women's health physio. There may be a naturopath involved, etc. But just making sure that your practitioners and health professionals and medical professionals are all talking, and the focus is you in the middle there, and often you have to advocate for yourself with your GP. So just making sure that you've got a team that's really supporting you.
Yeah, love that. Great, Rex. Great, Rex. So we hope you enjoyed today's episode of Delve as we talked about the topic of the oral contraceptive pill, and from the wonderful Dr. Nancy Peters and her insights on the pill. Stay tuned for our next episode of Delve, and we look forward to seeing you there. Bye.
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 Thank you for listening to this week's episode of Delve and being a part of our community. Follow @TheDao on Instagram to vote in our polls and stay connected. Ask our team a Dear Dao Does question via the link in our show notes. And for more information and to sign up to our newsletter, visit our website.
The content provided on this podcast is for informational and educational purposes only. It's not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a qualified healthcare professional with any questions you may have regarding a medical condition.
Leaving a review on Delve helps others to find our show and increases awareness for women's health and traditional Chinese medicine. We would love if you can take a moment to like, subscribe, and share. This episode was recorded on Gadigal land. Always was, always will be traditional Aboriginal land.